You've responded to the scene of a 28-year-old male with difficulty breathing. Upon arrival, fire department personnel meet you at the front door of the residence and state they have just begun CPR. They continue to explain that the patient was minimally responsive and breathing with an increased effort upon arrival. While they were obtaining vitals, the patient began gasping for air and no longer had a pulse. They've attached an AED and no shock was indicated at the first rhythm check. What is your initial impression of the scene? So my initial impression is that it was a witnessed arrest by fire and early CPR was initiated. And then one of the things you want to think about is the criteria for death. There obviously is none at this point. And then he's also a very young patient. He's only 28 years old, and he was having trouble breathing. So a possible cause of his arrest could be hypoxia. And then you still want to keep in mind your other reversible causes, go through your H's and T's. And then if we're the only ALS truck on scene, we want to request another truck. And then we want to assign roles between my partner and myself. And then if family was around, we want to still think about our sample, maybe have fire get that for us. And then we want to look for maybe meds around the scene to get a better idea of his medical history. So the no shock indicator from the AED likely means the patient is in what cardiac rhythm? So the only shockable rhythms are VTach and VFib, so he's in either PEA or asystole at this point because there's no shock advised. You are now in charge of the scene. You have as many personnel as you need, but you're the only paramedic. Everyone else is EMT. Explain what you will do to begin leading this call. So the fire department right now is doing compressions and they began CPR, so if they're tired, we want to have them rotate out. And then we want to attach our cardiac monitor and get an EKG. And then also we want to attach a nasal cannula for passive oxygenation during this. And then we also want to get an ETCO2. If the ETCO2 is less than 10, we want to fix our compressions. We want to be doing at least 100 to 120 a minute at a 30-to-2 ratio, and then we want at least 2-inch depth or 1/3 the AP diameter. So once we print out our EKG, we look at it. So once you place the patient on your cardiac monitor, you see the following rhythm. There's no pulse. What is the rhythm? So this would fall under PEA. And then in addition to CPR, what initial interventions will you provide for this patient? So we want to insert an airway, and then once we do that, we can do one breath every 6 seconds. So we'll either use a King or we can intubate our patient. And once they have an airway, we can do continuous compressions. We also want to pre-charge our monitor in case the rhythm switches, so we're prepared to shock our patient. And then we want to obviously establish our IV or an IO. And then he's in PEA, and the most common causes of PEA are hypoxia or hypovolemia. So we want to hang a bag of normal saline because this could be one of the reversible causes that we could begin to treat. So we're going to hang a normal bag of saline, 500 milliliter bolus, and we're going to keep it wide open. And then at our first rhythm check, we're going to administer epi, 1 to 10,000 concentration. We're going to make this by putting epi 1-to-1 in a 10 milliliter saline flush, and we're going to administer 1 milligram. And then at our second rhythm check, we're going to re-look at our EKG, and we're going to do a pulse check. And then once we've gotten to our third rhythm check, we're going to re-administer our epi because we're giving it every other rhythm check. And then we're going to check pulse. We're going to reprint out our EKG, and when we print out our EKG, we see that his rhythm has changed to VFib. So immediately we want to defibrillate our patient. We want to defibrillate at 200 joules or the manufacturer's recommendation. We have the Zoll, and the Zoll's recommendation is 150 joules. So our monitor is already pre-charged to this, so we can shock right away. Your patient remains in the rhythm from question 6 for the next 12 minutes. Explain your treatment for this time period. So for the next 12 minutes, he is going to remain in VFib. So our fourth rhythm check, we're going to do pulse check, rhythm check. We're going to check his carotid pulse, and then we're going to reprint out our EKG. And look at that. This should take no longer than 10 seconds every time we're doing our rhythm checks. And then since he's still in VFib, we can defibrillate our patient at 150 joules again. And we also want to pre-charge our monitor for our next rhythm check, so we're ready to defibrillate. So at our fifth rhythm check, pulse check, We're 10 minutes into the call at this point, and we want to print out our EKG. We want to defibrillate our patient at 150 joules, and then we want to re-administer our epi, and we also want to give amiodarone, and we're going to give 300 milligrams IV push. Now at our 6th rhythm check, we are going to rotate compressors throughout this as needed, and then we're going to defibrillate at 150 joules, and then our 7th pulse check, rhythm check, we're going to administer epi, and then we are going to administer our 2nd dose of amiodarone, and that's going to be 150 milligrams IV push, and then also we're going to defibrillate. And then at our 8th rhythm check, we're 16 minutes into CPR at this point, and we're going to do our pulse check, rhythm check, reprint out our EKG, and we're going to defibrillate our patient at 150 joules. And then our 9th rhythm check, we are now 18 minutes in, and we're going to do pulse check, rhythm check. We've already given both our doses of amiodarone, so we're only going to give epi, and then we're also still going to defibrillate. So what additional intervention may you consider following 5 unsuccessful defibrillation attempts? How was this procedure performed? So we're going to do dual sequential defibrillation. This is performed by taking 2 separate cardiac monitors, hooking them up to the patient with a 2nd set of pads. You want them on the front and back, or you can have them opposite to the pads you already have on. And we're going to defibrillate one after another. So the first monitor will defibrillate, and then the second monitor will defibrillate at both at 150 joules. So after we've done this, we get a pulse back. So following this treatment from question number 8, a carotid pulse is noted at the next rhythm check. The following rhythm is noted on the cardiac monitor, and the patient's pulse rate matches. What is the rhythm? So this rhythm is SVT. There is no discernible P waves. It's rhythmic, and it has a rate of over 150. What considerations do you have in treating this arrhythmia? What other assessments will you perform this time? So considerations is that we've given him a lot of epi, so tachyarrhythmias are common following ROSC. So this isn't like a huge concern of ours at this point because this is very common. We expected to possibly see this. And then for what other assessments we perform at this time. So he's basically a new patient at this point, so we want to start back with our ABCs. So our airway, breathing, circulation, skin color, condition, temp. We want to get a new set of vitals, and we want to reassess our patient. And then after 4 minutes, your patient remains unresponsive with no spontaneous breathing. Your 12-lead ECG is unremarkable. Vitals are as follows. So we still have a heart rate of over 150, it's 174. Our respiratory rate, we have placed an airway, so it's assisted at 12 breaths per minute. Our SpO2 is at 97. Our BGL is 202. Our EtCO2 is 55. This is out of the normal range, but this was expected to have a high EtCO2 following ROSC. And then our blood pressure is what's most concerning out of these vitals. It's 62/30. Why do you think the patient is hypotensive? What interventions do you feel are needed at this time? So we're going to hang another bag, if needed, of normal saline. This could be a reason that he's hypotensive. He could possibly be hypovolemic, and that's causing the low blood pressure, so we're going to hang another bag to try and reverse this cause. And then also, he may be hypotensive because his heart is not pumping a lot of blood because it's in SVT and it's beating so fast. And then if your initial interventions have no effect on the patient's blood pressure, his vitals remain relatively unchanged, what additional treatments will you consider? So we could give him a vasopressor. We could give him Levophed, which is norepinephrine, at 2 to 4 micrograms per minute IV. And we're going to use IV pump tubing because we want to be as specific as possible with this medication. And then another treatment we could think of is synchronized cardioversion at 50 to 100 joules because he is an unstable SVT. He has a pulse, so we could possibly cardiovert him. And then explain the difference between the use of epinephrine, dopamine, and Levophed for the hypotensive patient. What type of shock may each be better suited for? So epi may be better suited for a distributive shock. We give it for anaphylaxis because it's beta-2 agonist. And then dopamine is best for cardiogenic shock because of the effects it has on cardiac output. We wouldn't want to give Levophed for cardiogenic shock. It'd be better for a distributive shock, because a distributive shock is a widespread vasodilation, and norepinephrine works with alpha-1 receptors and causes vasoconstriction, so we want to give something that constricts the vessels if we have widespread vasodilation.